So everyone that's here really wants to be here as the last session. Thank you. So we're going to talk about value-based contracting, and we've got Jay and Corey here. To start us off on the topic, Jay, we've used the phrase value-based contracting throughout the last 2 days. Can you help us? Can you sort of set the stage? What does that term mean to you?
Yeah, I think value-based contracting is perhaps one of the most important innovations that has happened in the health insurance business. It essentially helps us redefine how we pay for services and products. Historically, we've paid for services and products based on units of services and products that are delivered to our health plan members. With value-based contracts, value-based payment, we redefine that by aligning payments to the value that's created in the care of patients, our health plan members, and shift away from the measurement of units and paying for them. And what this does is it aligns the incentives of providers of service and products to the creation of value, to improving the outcomes for our health plan members and reducing costs.
Corey, how do you define value-based contracting?
I see it largely the same way. I look historically back at the changes in reimbursement structures over the past 20, 30 years, well before I was even in healthcare, from total capitation, total risk, into fee-for-service. And now I think in some ways we're splitting the middle in a way where we take risk not globally, but we take risk by service line, we take risk even by device that gets used or pharmaceutical that gets used or specific approach to a given surgery. And I think that's a lot more manageable from an individual provider's and a health provider's perspective. It does, though, increase the data needs. And so if we're taking delineated risk on smaller and smaller portions of a healthcare delivery, then we need appropriate data. We need ways to measure outcome. And so it's a really compelling space that I know we've been involved in for going back now 10 years. And I'm glad to see that it's continuing to evolve and find traction both on Medicare and Medicaid and commercial as well now.
So over the last couple of days, we heard some great applications for the technology in terms of how people are solving for inefficiencies and other things in healthcare. And Jay, what are you doing? What's your organization doing right now, and where do things stand today?
Yeah, so in terms of value-based care, I mean, there is, from our perspective, we've had a growing number of providers that are in some form of value-based arrangement with us. And that portfolio of value-based contracts with providers has grown tremendously over the years. And it ranges from simple fee-for-service plus pay-for-performance all the way to upside, downside, 50-50, shared risk, in our joint venture models. And while this has grown, the provider value-based contracting has grown. What's also started, and it's grown quite a bit as well, is value-based contracting with other providers of products and services. For example, pharmaceutical manufacturers. We've got now a growing portfolio of pharmaceutical products that are in value-based contracts with us. So the idea is the same. It's to move away from reimbursing for units of product that are delivered to our members and move in the direction of reimbursing for value creation. We've got a few value-based contracts with medical device manufacturers. We did one with, or a couple with insulin pump manufacturers last year. We've got value-based contracts with providers of digital health solutions and services to our members. So really, we've got value-based contracts with a variety of different stakeholders in the healthcare ecosystem. So it's definitely, from our perspective, something that is of a lot of interest to us, the value-based model, and it's something that we certainly intend to grow over the years.
And what, in terms of how you look at those contracts, what are some of the obstacles and challenges that the organization's faced?
I think in terms of the vision for the future, right? So how, where things stand today versus where we want to be, a few years from now in making our approaches to value-based contracting more sophisticated. One of the opportunities is really looking at all of these different stakeholders in the healthcare ecosystem and devising mechanisms to evaluate value creation in a much more integrated, patient-centric fashion. So when we look at value creation from our perspective as an insurer, when care is delivered to one of our health plan members, to an individual, and value is created, we can measure that very objectively, right? And then we can measure what the contribution of each of those different stakeholders in the ecosystem was towards the creation of that value. So what was the contribution of the provider versus the pharmaceutical manufacturer versus the medical device company and the digital health solution. And then, once we can do that, then we can also figure out in a multi-stakeholder fashion how that value should then be attributed to all of those individual stakeholders in the ecosystem in a sort of multi-party value-based contract in the future. And really to go down in that direction, what you really need is cross-industry, cross-party alignment on the definition of value creation, and also alignment on the rules that attribute the value to those individual members of the ecosystem. And to be able to do that, you need a tremendous amount of data transparency and trust between the different members of the ecosystem, right? And really, I think blockchain might be a good solution to address those needs.
Corey, do you have anything to add?
Sure. I mean, I think you eloquently described where blockchain is needed. You've got multiple parties. You've got some data transparency issues, but you've got multi-party coordination issues. And by tradition, enterprise systems have been interiorly focused. At best, serve as a communication point with a single other party. Very few enterprise systems have been built and operationalized to coordinate multiple independent entities around a given function. And in healthcare, we uniquely have the patient or the member at the center and should always remain at the center of that coordination and orchestration around it. And I believe that's the promise largely of what blockchain can do, which is help independent parties coordinate in a trusted fashion. We can argue about the level of transparency that's required, the level of control or coordination that's required by each and all those parties. But I think we have a flexible new architectural approach to designing data systems that are focused on multi-parties first and not just as a secondary order of how do we communicate what we've determined internally here. As I think about coordination inside value-based care, at least from the provider side that I can speak to from our experience, taking risk and managing risk is something completely new for a lot of the way that provider organizations have been structured over the past decade and a half. And so there's a real need for these tools, not only from administrative purposes of calculating who gets paid what, but how do we manage that risk? How do we remain informed? How can we intervene in time, course adjust in the middle of an episode or other type of definition so that we can always act in the best interest of the patient, of the patient. Freudian slip there. And so, I think there are a range of kinds of features and functions that are necessary. Some are administrative and payment, some are care coordination. But I think the beginning to put these things together, and so that care coordination is both patient-centered and tied to the financial arrangement as well, is the way we get coordinated effort more efficiently.
The other opportunity as well is more sophisticated definitions of value, right? Today, most of the measurement of value is done by insurers using claims data. And that is a rich source of clinical information. You can get a certain degree of depth into the clinical profile and measurement of value. But the limitation is that apart from the fact that it takes a lot of time to get in the system and be able to be ready for use, it is also the fact that it's cross-sectional data, right? So claims are generated when services are provided, right? And that represents, if you think of, a year in the life of a patient with a chronic condition. They might see their physician a few times, right? And claims are generated at those cross sections in time when they see their doc or any other provider. But in between those visits, we're not capturing any data in a longitudinal fashion that tells us what the health status is between the visits. And there's a great opportunity there of incorporating in our definitions of value, in our assessment of clinical outcomes and value, how the individual is doing with respect to the health status between those visits by collecting things like patient-generated data, from wearables or self-reported data, what have you. I mean, there's great opportunity to incorporate all of that data into the measurement of value.
Well, and what you're talking about in terms of how we move forward, what success look like in this area? I mean, you described some of the inputs and around data collection and timely data in terms of what we do with it. In terms of your experience, what is it? What are the learnings, and then how do we move forward? What does it look like in the future?
So there's two questions there. I think one is, what does success look like? And really, success is in better serving our patients, right? So in improving outcomes. And really, if you think about value-based contracting, that's a tool or a mechanism to get to that end goal, right? And to the extent that we can create sort of cross-ecosystem transparency and incentives to better serve our patients, to improve their healthcare outcomes, then that's a huge win. I mean, that's where we want to get to. Now, it's a far-flung goal, right? It's a vision today. It's not anything we're close to. So really, to get to that point, I think what's really important, and that gets to your second question, is how do we get there? Is take a more pragmatic approach to the development of that ecosystem that can then do that. And to do that, we really have to start with more meaningful, pragmatic use cases that can create value today, as opposed to the more futuristic ones. And you can do that by targeting things that immediately create value through administrative, operational synergies, cost synergies, by reducing the administrative burden of performing certain activities that are being performed today at a certain cost. And when you have those short-term wins, you are well positioned to take a longer-term approach then and address some of the bigger value propositions.
I would largely agree. I think in the short term, we have to create efficiencies to allow us to scale these contracts and their administration far more easily and with far less cost and friction associated with it. I think that's also important in prepping the provider. Right now, the best strategy for provider organizations to take risk is to consolidate wildly. And so that's been one of the drivers in the consolidation on the provider side of the market, in which case I need control of ambulatory care, of primary care, of clinics, of lab, and of hospital, and then now of post-acute as well, in order to sufficiently take risk and be able to successfully manage that risk. And so I think as we build practical tools to solve the problem now, we enable providers to more easily engage in these contracts without having to build a very large ship, which is very difficult to steer in order to manage that risk. I think once we have that kind of acceleration of scale, to Jay's point, I think we begin to iterate on new models. I'm always sensitive to how much change a very complex system can take at one time. And I think a very interesting new direction that hasn't been discussed is how can a patient's performance under value-based arrangements carry from payer to payer. I mean, because we know that in the commercial book of business, patients and covered lives switch providers almost annually. How many people have had the same insurer for more than 5 years, right? It's like every plan year there's a new offering, I get a new card in my wallet, and it's like starting with a clean slate. And if we're going to be incenting both providers, device makers, and pharmaceutical manufacturers to bring the patient more into it, but we need really a passport to say, here's where I've been, here's what's been done, and now I can carry that benchmark from one payer to another. And so, I mean, I'm really thinking about it in terms of value-based interoperability between payment regimes, between payers, in the same way that I move from provider system to provider system as I move through an episode of care. And so I think that's some interesting future ground to look at, but I think our immediate goal is efficiency and the ability to scale without so much expense and/or operational risk.
Good, that's helpful. So in terms of the data driving insights around how we better care for patients, it sounds like, I mean, as we look at this and we have a dashboard that really helps us do that with our clinicians, it helps us understand and potentially collect patient data. Do we get closer to being able to really isolate quality in healthcare?
Yeah, I mean, I think, measurement of quality is just one thing, right? So the dashboards and the data will give you information about what the quality of care is and where the opportunities are. But the other piece of it is the intervention, right?
Right.
So what are you going to do about it? And value is truly created when you have sort of the yin-yang of the insights and then the intervention as well, right? It can't be just one thing or the other, right? You've got to have the insights, know where the gaps are, and then fill them. So I think having the information is key, but is not sufficient in creating value.
I think quality and value are highly contextual, and so the weak point in all of our systems is, do we have the data available? Is it reliable? Is it quality data in and of itself? Can it be relied upon? Is a challenge in healthcare. And I had an interesting conversation earlier today about EMRs with someone who said EMRs will really take off when people have a reason to really have an EMR, apart from the government subsidy that was used to purchase it in the first place, but it's that it's not only the source of your claims generation on the provider side, but it's a vital data source in some of these new style contracts that we're imagining. And so interoperability is not just a good unto itself, it has a practical value in helping feed a broader data ecosystem for new payment innovation.
Good. Any parting or wisdom for this group? I mean, we're all, sort of looking for inspiration around the mission that we're trying to bring about change and drive some of the inefficiency out of healthcare by what we're doing. Any wisdom around what we should think of as we try to work with organizations like yours?
Yeah, I mean, like I said, I think this is a very promising technology, and it's a great time to be in healthcare right now with a great opportunity for disruption. And I think really focusing on short-term use cases that generate value with a longer-term vision in mind, so that it's not just that you're solving for individual use cases without having a long-term vision. You've got both. You've got what you're doing next, and then you've got a longer-term path as well. And I think that's the best way to approach it.
Good. Well, thank you. We appreciate your time and
Thanks.
having a chance to talk to you.
Thanks to Jackie.
Thanks.
Thank you all.